Hello, everybody. My name is Ram Imani. I'm one of the cardiac surgeons here at Boston Children's Hospital. I am the director of the adult congenital cardiac surgical program, and I'm also one of the heart valve surgeons here at Boston Children's Hospital. And I also operate at MGB Brigham and Women's Hospital. And we're here today to talk about aortic valve repair and replacement options. And with me is Lauren Marshall, one of our engineers who helps with the valve program. And we're going to talk a little bit today about how we approach uh, aortic valve repair or replacement. And I'm hoping that we can have a nice conversation here to talk about some of the nuances of this. And Lauren, yeah, we spent a lot of time talking about valves together, and you from the engineering side, and us from the clinical side. And I'm hoping today we can kind of share a little bit about how complex the aortic valve really is, and how we approach a personalized management. It certainly seems like over the past few years, there have been an increasing number of options for treating patients with the aortic valve disease, and we've certainly talked a lot about that at our conferences. Um, Maybe I'll let you introduce yourself and talk a little bit about how you've been involved with the aortic valve program.
Sure. Yeah, hi everyone. It's nice to see you all. My name is Lauren Marshall. I'm a master's trained engineer and I work here at Boston Children's Hospital in the 3D modeling and simulation lab. So we're kind of a unique center here. We're one of the only hospitals in the world that has a team of dedicated professional engineers working with the cardiac surgery department to do 3D modeling and quantitative planning for a lot of the surgeries that happen here. We do an immense volume of 3D modeling. We have modeled about 60% of all of the cases that have gone to surgery here at Boston Children's since the program has started. My specific role on the team, like Dr. Amani said, I work with the aortic valve modeling program. So, what that means is every patient that comes here for aortic valve repair or replacement gets a CT scan before surgery, and then I make the 3D model. And we do a set of quantitative measurements and things and analysis, and we present those engineering analysis results at our weekly valve conference. So it's really transformed the way that the surgeons and the engineers talk about valve repair and approach valve repair. It's really boiled down more to a geometric and an engineering problem, which makes our center really unique. So I've been doing that for about 4 years. And I have about 10 years of experience with working with mechanics of soft tissues, including heart tissues.
Well, thanks, Lauren. And we're going to certainly dive a little bit into what you do. Um, and I think the to help sort of kickstart some of the conversation, I'm just gonna share my screen here to kind of talk a little bit about what we're talking about. And I would say this is kind of a one of the models I think you created, Lauren, of the aortic valve, and it's really a very complex structure. The normal aortic valve has three leaflets, and what it does is during when the heart squeezes, obviously it opens widely, and then when the heart relaxes, these valve leaflets come together like you see here. Creating a perfect seal so that blood flow doesn't go backwards into the heart. So there can be multiple problems. Aortic valve stenosis is a condition in which the aortic valve leaflets don't open all the way. And aortic regurgitation is where the valve leaks when it's trying to close. And I think it's I think it's a very complex structure that we've come to appreciate over the years. And this is something that I think is going to come out as we start to talk a little bit and have some conversations about how we approach a patient with aortic valve disease. Obviously, when do you intervene on someone with an aortic valve disease is a very important question. I tend to find that patients will be asymptomatic for a long period of time. But if you don't have symptoms and you start to notice that the heart muscle is increasing in size, or the heart is starting to see the effects of either stenosis or regurgitation, that's when I start to think about addressing the aortic valve. This in and of itself is a complex decision. But I won't spend a lot of time talking about that because I really want to get into the treatment options, which is really where there's been a lot of development over the past few years. Um, Aortic valve treatment, Lauren, you know this, that for the in the past it was always an aortic valve replacement. I mean, you recall even 10 years ago when a patient came in for with aortic valve disease, we were talking about what kind of valve are we going to replace it with? Is it going to be a biological valve or a mechanical valve? And those were really the choices. That this was kind of the way that we practiced medicine for a long time. And the real differences here in terms of valve replacement are there are biological valves, which are tissue valves. These tissue valves can be made out of either a cow or pig materials, um, and they work pretty well because they are designed to be aortic valves. The problem is they don't last for a long period of time, even if they work in the short term. I think we've seen many of these fail over time. And I don't know, Lauren, you've seen some of these valves when they fail. What happens to these tissue valves when they come back 10 years or so later? What have we seen on some of the imaging?
Yeah, it seems that the leaflets can get kind of stuck and they don't move as well, which can result, like you said, in stenosis. We can also see, particularly with the Ross, we can see a lot of dilation where the leaflets are not really long enough to be able to meet in the middle, since the whole valve structure is really kind of blown up, and you're getting a leak through the middle of the valve because the leaflets aren't touching.
Yeah, and that's the Ross procedure is an interesting one because I think that is something that's been around for a long time. And we're going to talk a little bit about the Ross procedure because I think it's a really good option. And there are a lot of patients that I've found do really well for a long period of time. But as you said, there are a few patients that do seem to come back with a problem, and particularly with the aortic dilation. And so that's something that we will talk about in a few minutes as well. There's of course the mechanical valves, and these valves are pretty durable, but they do require blood thinners. My colleague Dr. Kwan has just joined as well, and maybe Michael, I'll have you introduce yourself if you don't mind. And we just got started talking a little bit about aortic valve replacement options.
Fantastic. Thanks, Ram. So I'm Michael Kwan. I'm one of the congenital heart surgeons here at Boston Children's Hospital. And Dr. Amani and I are the two surgeons within our group that really focus the most on the care of adults with congenital heart disease. And so that's been a focus of mine since I've been here since 2020. And so really happy to be here talking about aortic valve disease, which is relatively common disease process that we deal with on a routine basis within our program.
Yeah, and Michael, I was just talking about first, I was going to get to valve repair in a second, but I was just starting off by sort of thinking a little bit about aortic valve replacement and the options of biological versus mechanical, or even transcatheter biological before we get to the Ross and the valve transplantation. and in the past, we really only had biological and mechanical valves, even up to recently. How do you typically, when you're counseling a patient about, let's say, if it was just between mechanical and biological, how do you think about it? What do you tell your patients about the differences, and how do you typically make the choice?
Yeah, that's a great question. So sometimes I think it's helpful just to understand historically how these options came about. And the mechanical valves were the first ones available on the market back in the 1960s when the specialty was first born, cardiac surgery, that is. And we know that the mechanical valves have the ability to last. Essentially the duration of one's entire lifetime, as long as blood thinners are taken to prevent blood clots from forming on those valves. And it was in the setting of bleeding complications that happened in a small subset of patients that there was a big push to make a type of valve that didn't require a blood thinner. And so that's when the biologic bioprosthetic valves came to be. And we have a variety of different types nowadays, but the one distinguishing feature is that they don't require a blood thinner because they don't develop clots on them as readily as a metallic surface inside the bloodstream. But on the other hand, they do develop significant amount of wear and tear, if you will, that causes a combination of both stenosis or blockage of the valve, as well as leaking of the valve in some instances. And so that's sort of the main dichotomy that we consider as we then approach an individual patient with unique needs. So if there's someone who really can't be on a blood thinner because they've had a history of bleeding in the brain or GI bleeding, or if there's someone who is of childbearing age and wants to carry a pregnancy in the future, recognizing that being on a blood thinner like Coumadin can increase the risk of birth defects and make bleeding complications around pregnancy and delivery significantly more risky. Those are patients in whom we would consider something other than a mechanical valve. And then for those who would be just fine with a blood thinner and don't have many of those constraints, particularly if they're younger, and there's a lot of premium that we're placing on the ability for a single valve replacement to really go the distance without needing to have multiple repeat procedures done again and again over the course of lifetime, which is sometimes the case with young patients receiving biologic valves. That's a situation where a mechanical valve makes a lot of sense.
What do you think about this new valve, the Onyx valve, and its lower need for anticoagulation? Is that do you think that we're going to be at a point where you can not need Coumadin for an aortic valve?
Yeah, that's a great question. There was a trial recently that was stopped in the early phases of the trial a couple years ago, where they looked at non-Coumadin blood thinners to see if they would be safe to take with an Onyx valve. And Onyx is a particular type of mechanical valve that's machined in a more precise way, such that it's less prone to clot, but you still need a blood thinner. And so right now, the state of affairs is that you can take a lower dose of Coumadin, but because the trial looking at other non-Coumadin blood thinners in the setting of an Onyx valve demonstrated a higher stroke rate with that presumably attributable to blood clots that formed on the valve and traveled to the brain, causing a stroke. That is not something we can do yet. Now, there are a lot of studies underway, including at our institution, to determine whether or not better dosing of non-Coumadin blood thinners and better monitoring of such doses can create a situation where a non-Coumadin blood thinner, like Eliquis or Apixaban, can be given with an Onyx valve in place. So that's something that I think will take at least several years for us to sort out and be able to offer to the public. But it would be a boon if that were the case.
Yeah, certainly. I feel like we've done that in some patients, and there's a question in the Q&A about other blood thinners being used or developed other than Coumadin that can be used when you have a mechanical valve. And I think the answer is people are trying. We certainly have some patients that we're treating with a non-Coumadin type blood thinner, an alternative type of blood thinner. But we just don't have long-term data to say that it's definitely safe. So I think that's still it sounds like that's still something that's gonna be a work in progress, and hopefully at some point we'll be at that point. What do you think, Dr. Kwan, about the idea that you put in a biological valve and then you go in with a transcatheter valve to do a valve and valve to kind of extend that and why not? How about that approach as opposed to a mechanical valve with blood thinners?
Yeah, that's something that's been done with greater frequency in the more sort of modern era, where transcatheter valve rescue, if you will, of a previous bioprosthetic valve is available. I think one thing that's important to recognize is that it's not a guarantee that one can get a transcatheter valve inside a bioprosthetic valve. Um, uh, and some of the constraints include the position of the coronary arteries and how close they are. Will they get obstructed if you put a valve inside a valve? Is the residual orifice, the size of the opening in the current bioprosthetic valve, large enough to accommodate a transcatheter valve and not have obstruction from the get-go? So these are some of the variables that make it so that not everyone who intends to go down this pathway can actually go down that pathway. And then the second thing that we have to consider is that there's a limit to how many times you can do that. Usually it's on the order of one and sometimes two. And for particularly young patients, even if they get, good 20, 30 years out of this strategy, it will come to a point where the entire valve construct needs to be completely re-replaced at some point in the future. And there have been a lot of reports that demonstrate that the surgery required to remove not just one surgically placed valve, but a surgically placed valve with multiple transcatheter valves inside of it can be more complex and thereby riskier in terms of post-op complications. Dr. Mani, have you had experience with that particular circumstance yet in the operating room?
Yeah, I'd say that I've been fortunate in that the ones that I've had to take out it hasn't been that bad. But certainly I think we're thinking the big catch term now is really lifetime management of valve disease, isn't it? And that what we're trying to accomplish here is to really, keep the heart as healthy as possible for as long as possible and avoid what you want to really avoid is needing to have an operation when you're in your 70s and 80s. And so as we're getting our patients to live longer, we want to try to get the most durable and best options that will get us so that we don't have to do that. So if we certainly putting in a biological valve at age 60 or so is reasonable, because you might be able to get 10 years out of that original valve, maybe another 10 years from a transcatheter valve and get, full lifetime. But if we're talking about doing it in a 20 or 30-year-old patient, again, I'm worried about now needing an operation, multiple operations, now when you're 50 or 60 years old. And so I think trying to kind of time things so that you're as healthy as possible when we're doing, the definitive operation. So I feel like we spend a lot of time thinking about what does it look like, predicting the future given an option.
Yeah. Dr. Amani, we've focused a lot in the recent past because of this conundrum particularly for the younger patients, focused a lot on trying to improve our techniques and outcomes for aortic valve repair. Can you talk a little bit about what the evolution of that has been and where we're at?
Yeah, great. I think we're finding ourselves understanding the way that these aortic valves work, and really thanks to Lauren, who I'll ask her in a minute to kind of explain how what she's done to help us understand the valve. But we've realized that there are many valves. If the leaflets themselves look healthy, it really, it really is best to try to repair the valve if you can. And there are certain, what we call the mechanisms of the valve failure that we're now able to delineate very precisely with some of our new techniques. And we can understand that. We sort of get together and talk about this on a regular basis, and try to strategize for valve repair. And if you can repair a valve now, that could potentially be a long-term solution that doesn't require us to put in a valve that's not working. And so there are a number of techniques. One that's just using your own leaflets. Another is something known as the Ozaki technique. These are all techniques that have been developed, and it all starts really with understanding kind of what the anatomy is. And maybe Lauren, I'll turn it over to you to kind of share a little bit about what you do to kind of help us understand how we need to repair these valves.
Sure. I actually have some slides that I can show that goes a little bit more in depth into our modeling techniques.
Sure.
All right. All right. So like I mentioned before, I make all of these 3D models. So this is what we're talking about. When I say 3D model, it's a 3D reconstruction that's made from your CT scan. So this is one slice. Picture A here is one slice of a CT. So that's one 2D image. And when you stack a bunch of 2D images on top of each other, you can generate this 3D volume, which is in figure B here. And so this is a really great advantage for the surgeons because they're not having to reconstruct these 2D slices in their head to visualize what your anatomy is. They're able to just very quickly see what's going on in your heart. And so if I play this video here, this is a patient's heart. The models are great because you can turn different parts on and off. You can rotate them around. You can make things transparent, and you have these cut planes, which allows you to kind of look inside all of the structures on a 3D model. So the advantage here is we can get the exact view that a surgeon is going to have in the operating room just on the 3D model. So before you even come to the hospital, before you're in the operating room, we're able to analyze your valve. And another advantage is this is the heart when it's pressurized. So you're in the CT scanner and your heart is beating like normal. When you're in the operating room and on bypass, the heart is deflated. So the tissues aren't stretched and pressurized, and they don't look the same in the operating room as on a CT scan. So this is another advantage of the modeling. And then what my job is to come in here and dimension out this whole valve structure. So we can take exact measurements of a lot of different structures of the valve apparatus from the 3D model. And we can compare those to the known relationships of a quote unquote normal or normally functioning aortic valve. And we know these geometric relationships from literature and other studies that have been done over the past several decades on studying normal anatomy. So what that creates is an engineering analysis that we can present. And this is what we talk about in our weekly valve conference. So all of the clinicians get together, surgeons, cardiologists, research fellows, and engineers. And we talk about every patient coming to surgery for aortic valve repair or replacement that week. And every patient gets this analysis done, and we talk about whether repair is possible based on the geometry of that patient's valve. And we also talk about other replacement options if that's preferred, and from like the surgeon's perspectives as well. So this is the measurement sheet that is created. So I'll kind of walk you through the information that we deliver to the surgeons, and then maybe Dr. Amani and Dr. Kwan can talk about how they deploy the data in the surgery. So in the top panel here, this is a quick view at a glance from the side of the vessel, if you will. So this is a schematic looking at the ascending aorta down to the sinotubular junction, which is where the leaflets hang from, all the way down to the annulus. So this blue shaded region is what a normal valve looks like. You can see it tapers down to the STJ, and then you have the sinuses that kind of bulge out, and then the annulus here is where it meets the ventricle. The black outline is what this patient's anatomy is now. So you can see it's outside of the blue. So everything is dilated. It's bigger than what it should be. And the numbers are in red here. These are the diameters that we measure off of the 3D model. And they're red because they're outside of the normal range. So that's a very quick indicator to the surgeon or the cardiologist that something is outside of normal. In the middle here, this is your surgeon's view of the valve, just kind of boiled down to a schematic drawing. So this mimics this picture C over here. And you have the measurements of each of the 3 leaflets on the valve when the valve is open, which is called systole, and when the valve is closed in diastole. So we measure the lengths of the leaflets, the heights of the leaflets, and again, the diameters of the tube or the STJ that the valve sits in. So using all of this information, we can then compare the existing anatomy to those normal geometric relationships that's known and published in the literature. So then we come down here to our tables if we wanted to do a 3 leaflet repair or a bicuspidization repair, which we'll talk about a little bit as well. We can say, okay, so for this patient, they have a 26 millimeter STJ diameter. We look up 26 on this table. That means that the patient needs leaflets that are 33 millimeters long in length. But we know that these leaflets are a little short. So that actually explains why this patient is having regurgitation or a leak through their valve. The leaflets are too short, so they're not able to cover all of the area that's inside of the tube. So to repair this valve, this is where we kind of talk with the surgeons. We talk about, well, you could lengthen the leaflets or you could reduce the diameter of the tube. And we talk through the pros and cons of all of those different considerations. And if we're lengthening leaflets, we talk about what patch material we're going to use. So the whole purpose of doing all this is really just to give the surgeons more data and numbers that can help guide their repair to know whether or not a valve is repairable, and if so, how much do they need to reduce or lengthen things by in the operating room.
Yeah, and I feel like this is definitely something that is, in the realm of congenital heart surgeons. There was one question in the chat for an adult with congenital aortic valve disease. What would be the reason or advantage to see a pediatric or congenital heart disease surgeon, considering many adult cardiac surgeons also do aortic valve surgeries? And I think this is the difference. So, most adult cardiac surgeons are replacing, like we talked earlier, biological and mechanical. Maybe the Ross if they're a specialized Ross center. But this whole realm of aortic valve repair, which is particularly the realm of the congenital heart surgeon, because we do this on a regular basis for not only pediatric patients but also for young adult patients. And I also feel like some of the other options that are now available with the valve transplantation are very much congenital heart surgery based. And so our repertoire, our options for treatment have really expanded quite a bit over the past few years, and so this is a reason why I think that there's a lot of nuances here. So we've been spending a lot of time thinking about that. I want to move on to talk a little bit about the Ross procedure as well. But Lauren, just to talk about, that you mentioned this thing called a bicuspidization. So many patients with aortic valve disease might have either a single cusp valve, which is shown here, or a bicuspid valve. And a technique that we've really been championing and using quite a bit in over 100 patients now is this technique to do what's called bicuspidization, where you take the valve, you open it up, and then you can create what is essentially a 2-leaflet valve out of a valve that may have been single leaflet or not functioning well. And this is a technique that has really, I think, revolutionized the way that we treat patients. Lauren, you and your team have developed these calculators that, as you mentioned, you can kind of change some of the dimensions of the valve. You can alter the size, and you can get a sense of what it looks like in different dimensions. And this type of a calculator system really, really increases our chances of being able to get a good valve repair. And I think this is really exciting. It's not something that is done by most surgeons, but we probably have one of the largest experiences with this type of valve repair, and it's something that I'm really excited about and have been spending. I think we've been spending a lot of time doing this, and here this just kind of gives you a sense of. For aortic valve repairs, we've really gone to doing this bicuspidization technique, whereas in the past we would use other types of repair techniques, including the Ozaki procedure. And this really goes to show you that there's been a lot of evolution over the past 5 to 6 years in the management of valve repair. I do want to get to the Ross procedure. Maybe Dr. Kwan, maybe you could just talk a little bit about what the Ross procedure is and some of the things that we've done to try to mitigate some of those complications that Lauren mentioned earlier that have been seen in the past with the Ross procedure.
Yeah, absolutely. So the Ross procedure was invented by Donald Ross back in the 1960s, and it was a procedure in which the pulmonary valve, which is sort of like the sister valve to the aortic valve, controls the blood flow from the right ventricle to the pulmonary artery, was essentially harvested from the patient's own heart and then moved over into the aortic position so that you were getting an aortic valve and root replacement using the patient's own tissue. And the wonderful thing about it is that it is living tissue. There's the possibility of that valve potentially going the distance. The data shows that it doesn't last quite as long in reality as a mechanical valve, which is still the most durable, but it tends to last a whole lot longer than the bioprosthetic valves. You don't need a blood thinner. And so it's very attractive from those standpoints. The main sort of price that we pay when we do a Ross procedure is that you have to put a pulmonary valve that comes from donated human tissue, so that essentially you're making a one valve issue into a two valve issue. But there's increasingly accumulating data that shows that even with that considered, if the Ross operation is done in a high quality center with good acute outcomes, that the overall ability to restore patients' life expectancy back to that of the general population is better with the Ross procedure than it is with either a mechanical or a bioprosthetic replacement. Now, in order for that to be true, not only does the Ross procedure have to be done with low risk up front, it is a more complicated operation. As you can see, these coronary arteries have to be detached and reimplanted, and so there's some risk associated with that. But also the valve, the Ross valve, the autograft valve, as we call it, has to be durable and not develop leaking over the long term. And that's one of the Achilles heels of the Ross procedure, as it has been done in the past, where when you take a valve from the pulmonary position, which is used to seeing lower pulmonary pressures, and then implant it into a much higher pressure system, the aorta, there's a tendency for that valve to dilate over time. And it's kind of like if you have a double door in an auditorium where the size of the doors is the same, but the frame of the door increases, you get a gap in the middle. And so this is one of the problems that we've seen in some patients who've had a Ross procedure. Even though the valve worked well up front, over time dilates and you get leaking of the valve, and then you have to have another operation. So we focused a lot, and Dr. Amani led the effort starting about 2-3 years ago to enhance the way in which we support that valve from the outside so as to prevent the valve from dilating. And so there are some centers who use the technique seen in the middle panel where the front end and the back end of the valve are supported with this fabric Dacron material, which is sort of fixed in size. But even that doesn't necessarily prevent dilation of the mid-belly of, of the autograft. And so we've gone to now fully supporting the entire autograft with a Dacron fabric wrap, as you can see there, and also uh, further supporting just beyond where the autograft ends to make sure that the top of the valve, which is a critical component to try and keep at the same diameter, maintain stability over the long term. And so far, when we look at our own data, we've seen that there really have been no major failures of this technique, no early recurrences of aortic insufficiency that require a reoperation. And looking back at the last 15 or 20 years, there have been a very small handful of patients who, in the setting of having an unsupported ROS, have developed significant dilation leading to aortic regurgitation and the need for another reoperation. Those have all been in patients who have had the unsupported ROS. And so although it's relatively early for us to say what happens 10, 20 years down the line, just by reasoning from first principles and seeing what our early data has shown so far, we've had a lot of excitement adopting this technique for doing it. So far, we've seen very good outcomes with it. Dr. Ahmad, you want to comment further on that?
I really like the Ross procedure. I think it's a great option. It has to be done right. I think you got to make sure that there are a lot of subtleties to this operation, and so certainly it should be something on in our toolkit. And so if I'm seeing a patient, I'll sort of present all of these options, and we talk about kind of what's the best thing moving forward and fits with my patients' goals and based upon their activity level. The one thing I will say for the Ross is if you have high blood pressure, that's something that we watch out for because that can also lead to some of this root dilation that we see with the Ross procedure. So there are some things that have to be fit to that particular patient. And so this is kind of describing some of our techniques for looking at doing that Ross procedure. I want to just kind of mention really quickly, this is something that's really new. It's more investigational at this point, but we've done several patients where we've actually taken a fresh donor heart that's not being used for heart transplantation and used the aortic valve to replace the aortic valve. And the idea here is that you can get growth of the valve. And this graph shows, if you have a young patient with aortic valve disease who needs a replacement and you put in a human donor valve, you can get it to grow and behave more normally. Now, for an adult patient, we're not interested in growth of that valve, but we are interested in it remodeling and behaving like a living normal valve, and it certainly appears that may be the case. And so this is another new option. It does require a medication immunosuppression to prevent rejection of the valve, though. So that's, again, something that we talk about. We assess all of these options together, and we try to make our best case scenario. So I want to make sure that the point gets across that there are really a lot more options now for managing the aortic valve than we've ever had in the past. And we've developed a team structure here that allows us to really understand each patient's needs and really understand what their specific anatomy looks like so we can decide on which is the best approach. And we've only touched on some of the very, very highlights here of what is what is the best treatment for a patient. But it's a lot. There's a lot of judgment that goes into making these decisions. The reason why I think it's very important that you have a conversation, the decisions made together, but the goals are the same. The goals are to keep the heart as healthy as possible for as long as possible, and to reduce the number of times you need to go back to the operating room or the cath lab or reintervention. And that is what we're trying to accomplish with our approach. And then, of course, along the way, really just having a high quality of life. And so that those are really some of our goals. I do want to. There is a question in the chat that maybe I'll direct to you, Dr. Kwan. What are the clinical indicators that you monitor to determine when a previously repaired valve needs to be replaced? And then similarly, what are the outcomes for a second, third time, or multiple time replacement? Is it the same as the first time that you're replacing a valve?
Yeah, these are excellent questions. So, for an aortic valve that gets repaired, we always hope for lifetime durability. The reality is it's not always the case. And so that at least in a minority of patients, the repaired valve can develop thinning of the leaflets or stretching of the leaflets and develop leakage. Or if patch material in particular had to be added to a leaflet, that can develop scar tissue and a process called calcification, which is when it gets really hard and thick. Calcium is what makes our bones and teeth hard, and that leaflet can get calcified too and cause blockage. And so recognizing that it's usually not a process that happens black and white like overnight. It's something that's relatively gradual over time. By and large, this gradual change, if it were to occur, would be something that would be readily detected by yearly echocardiograms that would be scheduled by your cardiologist. And so what we normally see is that in the patients who develop some degeneration over time, that the appearance on echo will precede the development of patient symptoms such as shortness of breath, exercise intolerance. Those are the two most commonly seen issues that a patient would notice in their daily life. And so we would be sort of following together the progression on the echocardiogram. And then once it were to develop enough regurgitation or stenosis that it would be considered severe, and if that occurs in concert with the development of symptoms, that typically would be the sort of classic combination of elements that would prompt us to consider doing another aortic valve procedure at that time. And so whether that next procedure is a second repair or a replacement, that all depends on exactly what the valve looks like at that next point in time. We also recognize that in order to do another repair, you still have to have good material to work with. So the leaflet tissue still has to be good. And so over time, valves do develop a lesser chance of being able to be repaired. And that's the whole reason we do the analysis. Not everyone who gets an aortic valve repair analysis can be considered a good candidate for another repair. And so that's when we would do a replacement or potentially a Ross procedure or potentially a partial heart transplant. All the options are generally still on the table for most patients. In terms of what the impact is of having to have multiple operations over the course of lifetime in the event that were to happen, the body develops a lot of scar tissue inside the chest cavity as a response to the physical manipulation that happens during surgery. And over time, that scar tissue tends to build up and cause adhesions of one structure to another. That includes things like the aorta, the lungs, the breastbone. And so there is data out there, and this is also in concert with our own experience, that the more operations someone has had in the past, the more difficult it is to get back into the chest safely and to get someone safely onto the heart-lung machine so that we can do the operation that we intend to do without causing injury to the critical structures like the aorta, like the coronary arteries, like the chambers of the heart, and other structures that can get injured along the way when there's a lot of scar tissue that makes it difficult for the surgeon to sort of get the structure separated safely. On the other hand, this is something that we do on a regular basis because a lot of our patients have had multiple prior operations, particularly those who have required surgery beginning in their childhood. And so we've focused on a lot of techniques to make that process as safe as possible. And sort of that harkens back to the other question that we received earlier. What is it about a congenital program taking care of adults that's different? These techniques that developed, we have developed because we've had to. For aortic valve repair, as an example, in some young children where the valve is really small, there's really no other option but to to repair a valve or to do a Ross operation. And so as aortic valve repair and the Ross operation has seen waves of popularity in the general adult cardiac surgical community, as it's kind of gone in and out of style over the many decades since it's been around. Congenital surgeons, on the other hand, have always had to maintain expertise in both of those procedures because for some young children with small valves, there's really no other options. And so what we're seeing now is sort of this gathering of expertise where we've now got multiple different options all available within a program like this that we can then look at each patient and say, what are the unique features of this individual patient and how do they align with what the full armamentarium of options has to offer? How can we best match where a patient is at now, where they need to be, with the technique that will get them there? And so, we're sort of, with Lauren's expertise in modeling these valves, with Dr. Amani's expertise, with the partial heart, and with the things that we've done together to make the Ross procedure even more reliable and durable. This is something we're really excited about, sort of seeing how the future unfolds, because it's not just a mechanical versus bioprosthetic anymore like it used to be a long time ago.
Thanks. We're going to have to wrap it up soon, but there is one last question in the chat. Lauren, I'll direct this to you. In addition to quantifying aortic valve dimensions to evaluate feasibility for repair, how else are you leveraging your engineering team towards surgical treatments?
Yeah, that's a great question. Our lab is big. We have about 15 full-time engineers working on it, and the aortic valve modeling is a small part of what we do. We're deploying the engineering analysis in lots of different ways to many different types of surgery. We also have a team of engineers that work more hands-on in our wet lab. They test the tissues that come out of the OR and as well as like normal healthy donor tissue to help understand the biomechanics of these tissues so that we can help the surgeons really understand, for example, like at what force do the tissues fail, and that can help them inform whether or not they want to use that tissue in a repair. We also do other analysis like computational flow dynamics for some of the more complex surgeries that happen at Boston Children's Hospital. And we're always kind of refining and expanding our offerings for
Lauren, you
this
come
area.
into the operating room too. You're with us when we're doing the repair, which is kind of cool because we have a nice conversation about okay, this looks like this, and so you're not just in the lab or in the engineering suite. There is one last question. Can you be too old to have an aortic valve repair? And is heart tissue harder to repair after a long life? Well, I don't think age is necessarily a barrier, but the quality of the aortic valve tissue is important to consider. So, part of our workup involves looking at the valve tissue itself, and specifically if it's very calcified, then it's unlikely that we won't be able to repair that valve. That's typically when we're looking at some sort of a replacement option. But if the valve leaflets themselves are thin and pliable, and it's a geometric change, and this is where Lauren's group helps, then it may be amenable to a repair. And at that point, it really any age of a patient can undergo a repair. So I found myself doing repairs more frequently. Even if there's a little bit of calcification, that's okay. It's just if the entire valve leaflet is completely deteriorated, that's a situation in which we really can't do a repair. But um, well, I want to be respectful of people's time. Thank you all very much for joining this webinar. I hope this was helpful. And if you have any further questions, feel free to reach out to our team. And I want to thank Dr. Kwan and Lauren Marshall for taking the time today to have this conversation with me. And we look forward to seeing you guys on our next session.